Peter, I cannot imagine a world where antibiotics don't work anymore. So in terms of antimicrobial resistance, which is one of the leading public health threats in the 21st century, can you shed some light on what, you mentioned some things up there about some research that's going on, but what is being done globally to prevent bacterial pathogens from becoming more lethal than they are today?
Well, I think WHO is leading on this in terms of proper use of antibiotics. So in the UK, we're in a good position whereby antibiotics are only dispensed after a doctor has prescribed them. But in other countries, you can buy half a dose of antibiotics. So that just encourages resistance. So I have seen resistance growing in this country. When I started at Coventry, I never saw any CPE, that's carbapenemase resistant organisms. The first time we saw that, the patient was locked in a room. Everything going in there was single use or destroyed. But today, we see many, and I think we are not that fearful anymore, which is a bad sign.
Andrew, I have a question. Federico from Guy's and St. Thomas's. So you have the clinical standards there. Is that general or adult focus? Or you also have clinical standards for pediatric neonatal? That's my first question.
So the whole standards are for both. And so each standard will say if there is an alternative practice for pediatric or neonatal, otherwise they're for both.
Okay, thank you. My second question is with regards to MRSA bacteremia post-infection reviews that we had. And one of the main focus is the multiple attempts by the performer. Have you got any, is it indicated in the clinical standard of how many attempts does a performer needs to do? Yeah. And all the clinical standards there, is it going to be reflected on the EPIC-4? That's it, thank you.
Thank you. So EPIC-4, we're in the process. I'm only involved in the vascular access side of EPIC-4, and I won't be the final author, but I'm on the kind of the committee, if that makes sense. I don't know. But, so they won't be out for a while yet. So there should be nothing in there in conflict with any of the standards that are out at the moment, or because it's all evidence-based. And I know that from the EPIC-4 standards, and don't quote me on this, but I know that the vascular access element is being based on the WHO guidance on peripheral and central vascular access, which these will be compliant with. So there shouldn't be any surprises there. In terms of the difficult IV access side, it talks about difficult IV access, talks about having a difficult IV access pathway, and there is also an example of what that looks like. And the first thing that you should ask yourself is, when you cannulate or take blood from somebody, can I feel or palpate, can I palpate or visualize a vessel? If you can't see or feel a vein, then automatically that patient's going to be difficult to cannulate. So then you should think about in your organisation, what do I do to escalate that? Is there ultrasound? Do I have a vascular access team? Who is it? And if you know, the standards will talk about, if you don't have that escalation, then that's something that you should try and work towards, because we know that multiple cannulation attempts, multiple venipuncture attempts cause infection because it's a multiple break of the skin. And you know, even when someone removes the cannula and they put a big wad of gauze over it, they don't ever think, actually, I'll put a little waterproof dressing over that so that bacteria won't get into that exit site. So it talks about the number of attempts. The number of attempts will be 2 attempts by yourself, and then that needs to be escalated to somebody who is either in vascular access or an anaesthetist to have a further 2 attempts. And after that, then you need to escalate on to another device, because after those 4 attempts in total by 2 people, then the patient probably would need a vascular access device like a PICC line or something. So it's very clear around that. But it does say if you can't see or palpate a vein, you shouldn't even have an attempt. And that will reduce, because you see a lot of people, they would stick the needle in and jiggle it around until they get into the vessel. All that does is transfix the back of the vessel. Then that opens up not just in a risk of infection, but in a risk of infiltration. And so you put the drug in, you've got all those weak points in the tunica intima, drug can leak out, you can end up with chemical phlebitis or extravasation infiltration. So it's very clear. These standards are very black and white, and so hopefully it will enable you to kind of make the case in your organisation for that practice to stop, hopefully.
Just a quick question about, is there any provision for IV access used by radiography department or imaging department? We do give contrast via IV, and they're a bit viscous, as it were.
Yeah.
So is there any provision for that in the standard?
So in the extravasation infiltration section of the standards, it will talk about CT contrast, and it will talk about the difficulties, and this is also in the extravasation national toolkit that we wrote. We know there's a high number of infiltration and extravasation injuries through CT contrast in all hospitals because the national standard is to place an 18-gauge cannula in the antecubical fossa because of the flow rate. So all we can do is ask people to reduce that risk, so that would be things like placing the cannula so that at least 80% is in the vessel. So if it's a difficult cannulation, consider an ultrasound cannula or a longer length cannula. It also talks about doing your high pressure flush through the machine when the patient's arm is in the position you're going to scan, not when the arm is by the patient's side. Because we know you do the high pressure flush through the patient's arm here, and then you get the patient to put their arms above their head. And because the cannula is in the antecubical fossa and they bend their arm, it occludes the cannula, and then the contrast the high pressure will push the cannula out of the vessel and it will go into the tissue. So that's another thing you can do. You can site slightly lower the antecubical fossa, do your high power flush when the patient's arm is in position, so that then at least they only get an infiltration of saline and not contrast. We are working with the national organisations around ways of having the patient's arm by their side, but at the moment it's not easy because of artifact and the radiation dose. So, that's going to involve inventing something to put on the arm. So that's a long way away. But there are other cannulas you can use, and we talk about that. So there are perforated cannulas, and you can use a 22 or 24 gauge cannula for 3 mils a second, and you can place that cannula lower. And because it's got a perforation around the catheter, when the contrast goes in, it comes out of the perforation and goes into the patient, so it holds it still. And you could speak to BD in the lounge out there about those cannulas. That's another safety. So it addresses it.